Why don't we go ahead and let's go ahead and get started then, and folks can join as they're able, if they're able to join us today. So welcome, everybody. I do believe this is the last official task force meeting, given that we had a much more abbreviated list of things in the budget proviso to attend to this year. Doesn't mean the work of working towards the final report, which you all will all see a draft of as it gets put together, will not be done. A lot of this meeting today is going to be spent going over the evidence review that we've had, given the feedback that the team has received from you, and you'll hear some comments about that. Going to spend some time today also talking about the regulatory survey feedback that you were able to give to Duncan in his presentation of that. So this is really a way to kind of start to finalize and round up the deliverables that we as the Healthcare Authority have for this work. Doesn't mean the work is necessarily stopping. I know you all will continue to work closely in all of your advocacy lanes. We will continue to work on the reports and respond to any other further direction we're given from the legislature. Also at the end of today, have some discussions on the equity work that's happening. I did have a chance to join the equity subcommittee group last week and share some thoughts with them and got some feedback. And I think Dr. Price will be sharing that with a group if she's able to join us. If not, I certainly can do that. So with that, I think we can go ahead and get things kicked off. In the interest of time, Mike, I don't know if there's anything else you wanted to share that I was supposed to share but didn't think to mention at this juncture of the meeting.
No, Teresa, I think you teed that up really well. Thank you. And thanks for everybody for being on. As you see, we've got a full agenda to go through. Obviously, a lot of feedback from you guys. That you've done some survey work, but we also want to kind of feed some stuff back to you and get some additional responses. But then, as Teresa mentioned, as we are kind of taking all of kind of the meetings 1, 2, and 3, combining that into a final report, and we're kind of working with HCA to make sure that we then have time for you guys to have time for review before that is officially submitted to the legislature. So that's going to be kind of at the end. We'll talk about those next steps.
And just for a reminder to this group, our report is due on December 1st. Needless to say, government has a lot of process steps that we have to go through as an agency to get that approved and cleared. It has to go to a sort of another level of review before it even gets to the governor. That said, we will strive for the December 1st deadline, but want to make sure that we provide at least some time for everybody to give feedback so that we can get a product that we can share and submit to them. So I will take a hit if it ends up being a little bit late, but we would really like to ask that you, if at all possible, respond to any of the deadlines that we put out there. And you have been great. I really appreciate your timeliness on this. So just know it might feel a little bit rushed, and I'm sorry, but we have many layers of review that need to happen here. So just put all that in context. And I guess maybe we can turn it over to Bethany at this point.
Thank you, Teresa. Thank you, Mike. All right, I'm just going to give you a quick update from between the time that's passed since our last time together. Last time we spent most of the time talking about that evidence review, and that will be part of that final report, and you'll get a chance to dive more into the details at that time. I wanted to mention every systematic review, which is what this is anchored by the search dates when we're looking for the studies that we're going to include. And those search dates for this report were back in May. And then some of the hand searching for the journals was conducted in June, and the trial registry information was pulled about that same time as well. However, there were a few studies that were sent after the last task force meeting, and I did go ahead and review them to see if any of them would have been eligible for inclusion. One of the publications that was submitted, the Raisin et al. From 2023, which was published, I think, around August 31st of this year, was eligible for inclusion. The results of the study did not change the results or findings of the review or the evidence that we talked about last time. Essentially, they enrolled 104 participants with major depressive disorder and randomized participants to receive either niacin, which is a vitamin B or psilocybin, a single dose, 25 milligrams, so similar to some of the other studies we've already talked about. And they reported positive changes in depression scores, so decreases in depression at several time points after that single dose, so 8, 15, 29, and 43 days after that dose. So again, this helps add to the confidence that we have in the findings that there are individuals with major depressive disorder that have strong benefits from psilocybin, even at a single dose level in that dosing range. So you'll see that that study is described briefly in the discussion of the evidence portion of the report. I wanted to also note some of the reasons that the other publications that were proposed or submitted by email were not included reasons like they were conference presentations and were not a peer-reviewed publication, or they weren't controlled prospective studies with robust designs. And the purpose behind that description of looking for studies with robust designs that are controlled and they were planned from the beginning, the perspective, those types of studies, the results can help us understand the benefits and harms for individuals who are similar to those in the study, but that those benefits and harms we might be confident would be similar for other people on a population level. What's happening here is decisions that are being made related to a population of people, not decisions that are relevant to one individual's care. The other study designs we talked about last time and other publications that were submitted are really helpful pieces of the puzzle in research, and they can help flag areas for these robust designs of studies to be planned and carried out. That can help inform more of a population level estimate of where we might be looking for benefits and harms from something. But we would really be less certain about applying the results from a study of like a case series, for example, or a case study to a population level decision. So my encouragement for you all today, as we transition to Haley leading us through a discussion of identifying gaps that you think need to be addressed, is think about this in terms of gaps in studies with these robust designs that we've described in the evidence review. So what hasn't been studied inside of these randomized control trials or more prospective designs like the crossover trials, et cetera, that you would like to see that would contribute to understanding how these benefits and harms inside the studies might translate to a population level.
Bethany would be okay. And I just want to add a quick comment to that. I think that, the people who are going to read this are legislative members, hopefully, but they're staffers for sure, and the committee and their committee members. And so what I would say is I think we've been talking about evidence in quotes, the loaded term that is, for long enough now that I do believe many of them and most of them recognize that the gaps are as important as what we can confidently say does work. Mm-hmm. So I appreciate Bethany's comments, and we heard you clearly that is an important piece of what we need to highlight in this report for their viewing, to not say, well, we don't have evidence, we can't do it. No, it's that we have evidence that supports this group being impacted in this way, and we can or can't say that impacts that other group. So it's not that it doesn't work, it's that we don't know if it doesn't work. And I think that I think there's a better understanding of that distinction among folks outside of the scientific realm.
Thank you, Teresa, that was perfect. All right, I will hand it back to Mike and to Haley.
Thanks, I'll turn it over to Haley. Haley, thanks.
Thank you. Yeah, so like Bethany said, I think that was a great setup. We're going to try to work through identifying some gaps in the clinical evidence that Bethany just gave an update on. Next slide, please. To begin, I just kind of wanted to level set where this fits in with the scope of the task force. So like Teresa said at the beginning, the final report is due December 1st. The two major tasks in the bill were a clinical evidence review and a regulatory review. The regulatory review was addressed through that survey that you all completed and that closed last Monday. And then as part of the clinical evidence review, there were 4 requirements outlined in the legislation. Today, we're going to be focusing on the last one with the box around it, which is identifying gaps in clinical research. The other 3 were answered by the evidence review, but we would really like to gauge everyone's support and kind of crowdsource any gaps that we missed in the clinical research to make sure that everything is reflected appropriately in the final report. So that's kind of the goal for today's section of the agenda. Next slide, please. And this comes directly from the bill language. I just thought it would be helpful to kind of level set again that the directive was to identify gaps in the clinical research for the purpose of identifying opportunities for investment by the state, for the University of Washington or Washington State, or both, to consider studying. So that's kind of the frame that I approached the questions that we're going to go over with, and hopefully that's helpful when you're answering them. Next slide, please. We've also structured the identified gaps in the same way as a PICOS research method. So all of the gaps are presented under one of the categories, and we're going to be asking you all to identify or to rank the identified gaps in terms of your opinion of their importance for future consideration and research efforts. So we're going to go through each category: population, intervention, comparator, outcomes, and settings. And we have identified what we've seen as clinical gaps in or gaps in the clinical research for each of those categories, but we'll be asking you to rank and add anything we've missed. So that kind of sets up the structure for the next couple slides. Next slide, please. Okay, so in order to do this, we're going to utilize Poll Everywhere, which some people may be familiar with. If someone on the center team could drop the web browser link in the chat, that would be super helpful, please. You can join the poll on a web browser, or you can do it through your phone by scanning the QR code or texting CEPBOHSU 300 to 22333. All of those options should work. And we're going to do a test question in the next slide, so we have time. But let's see. Let's see if I can put it in the chat. Oh, thank you, Bethany. So yeah, if you all want to navigate to that website that Bethany just added into the chat, or join the poll on your phone, whatever you prefer, both should work. And you may be prompted to enter your name on the first slide when you first join. That's totally optional. I think you should have the option to skip it if you don't want to, if you want to be anonymous, which would be totally fine. If you're having any troubles, you can come off mute or add in the chat. Let's move to the next slide, please, Beth. Oh, perfect. Everyone is already way ahead of me. This is great. Thank you. So yeah, this is just a practice question. Looks like fall is winning. If you're having any issues, please feel free to come off mute and let me know. But it feels like we're rocking and rolling and people are responding. Okay. I'm sorry if you can hear a dog in the background, just ignore that. I think we're ready to move on to the first question, if that's okay. Perfect, thanks, Beth. So in this one, we're asking, again, all of the gaps will be presented in the PICOS category. So this is the identified population gaps in terms of importance for future consideration and research. So you should be seeing, I believe it's around 8 or 9 options, and you can drag and drop by the options in order to rank what you feel like is the most important population gap we've identified here. And I should also say, if you are thinking of something in your mind that's not included in this list, that is totally fine. The next slide will be an open-ended question where you can add in your identified gap. But just for now, if you can focus on the ones on this page, and if you're able to rank them. We'll give a couple minutes because I think there's a lot of options. Perfect. It seems like at least one person was able to get their responses in.
And Haley, we just let that go for a little bit since they're ranking a number of those. We'll let that run for just a little bit longer. Beth, if you're still controlling the screen, can you just maybe just use that scroller bar too and scroll down just a little bit so we can see the rest? Just, yeah, there we go. Thanks.
I'm seeing Dr. Price's comment in the chat, which I'll address while we're waiting for this. We are trying to gauge everyone's support in identifying gaps in the clinical research, which is part of what is required of the clinical evidence review of the legislative report due in December. So we just started, so you haven't missed any. The gaps are kind of structured in a PCOS research method. So we're starting with population. And we'll have 2 slides under each category. One where we're asking you to rank the identified gaps in terms of what you think is most important to be included in future research efforts by University of Washington and Washington State. And then the next question will be open-ended, what is missing? And we do have the whole mushroom research as a gap. It's not under population, but it is under another category. So it looks like we still have a little bit of movement. Oh, sorry, Mike.
No. And Dr. Price, I just want to make sure, I don't know, we may have to post that link again if you came in. If you didn't see Bethany's link, we can put that in there again so you have access to the poll everywhere. Let me see here.
Thanks, Bethany.
Thanks, Bethany. And we won't, guys, we just won't lock these right now. Or do we have to lock it to go to the next one?
I think we might have to lock it to move. Okay.
It locks when we move to the next one automatically.
Okay. Well, we give Dr. Price just another second here.
And Dr. Price, it's dragging and dropping to rank. Just a hint.
All right, Haley.
Okay, yeah, let's move on. And if Dr. Price, if you weren't able to submit your answers, we can work offline to get those from you. So we will move on now to the next question, which is an open-ended question. So you can type in your answers. Are there any population gaps in the clinical research that were not included in the previous question? So as you were ranking, did anything stand out as missing in terms of population characteristics? People with disabilities. That's great. Thank you. Elderly. Feel free to also put it in the chat if you're for some reason running into any issues with poll everywhere. Pain-related disabilities. It's very helpful. End of life care. Oh yeah. LGBTQ plus. Yep. Great. These are great answers. Thank you all.
Yeah, this is helpful.
Mm-hmm. This is great. How about we give it another minute or so, and then we'll wrap up. Indigenous populations, rural. Mm-hmm. Great. That is super helpful. Thank you all so much for adding those in. Let's give it 5 more seconds and then we can advance to the next one. Veterans. Okay, great. Perfect. Next slide, please, Beth. So then these are gaps under intervention. So things that we did not find in our evidence review related to intervention. So this is where that whole mushroom comes in. There's also was a lack of diversity or variety on the dosing levels. I know this, we've talked about microdosing a lot. Use of psilocybin for general well-being, not for clinical outcomes. That was something we identified. Co-ingestion, optimal number of psychotherapy sessions. So a lot of the studies were prescriptive in their number of psychotherapy included as part of their study design. Co-occurring psychological support, number of dosing sessions, and spacing of serial dosing. Those were some of the major ones that we identified. Again, if you could rank these, that would be very helpful. And then the next slide, keep in mind if there's anything missing from this slide that you can add to the next one. So we'll give, again, a couple minutes for this since it is ranking, and I know it takes a while. A nice feature would have been the Jeopardy music right now. That would have been added to the presentation a little bit.
We'll have to pull that in next time.
Next time, yeah.
I was waiting to see whole mushroom get moved back up.
I know.
Where I was.
Not to bias the results at all, but
Fair.
how about another minute or so? We're still seeing some movement. And if you want to, if we're waiting too long or going too fast, please let us know in the chat. Beth, do you mind scrolling if it's not too much trouble to see what else, where everything else is landing? Thank you. Okay. Great. Thank you. It looks like, oh, a little bit more. How about 30 more seconds and then we'll move on. Okay, it looks like there's not any more movement. So we'll close this one and move on to asking you if there were any missing intervention gaps that you thought about that were not on the last slide. Set and setting. Does anyone want to come off mute and maybe elaborate on that? Is it like the setting of the intervention? We do have, I think that is addressed later, but if you want to add any description to what you mean by that, either on the chat or coming off mute, that would be helpful.
Yeah, I was just thinking, was reading things like music and indoor, outdoor.
Oh, okay. Yeah, that's great. Thank you.
Can someone tell me what they mean by entourage effect of secondary compounds? I'm not sure I know what that means.
Oh, yeah. So where there can be other compounds in either the mushroom or sometimes even essential oils or terpenes that can modulate the psychoactive or therapeutic effects of the primary molecule, or psilocybin or psilocin. We see this in several other different psychoactive substances, and so I think it's important, especially if we're looking at the whole mushroom, to understand what that is.
Got it. Thank you.
Okay, great. Thank you all for these responses. Maybe another 30 seconds and then we'll move on. Okay, great. Thank you all for that. I think we're gonna close it and move to the next one, please, Beth. Great, thank you. So this is if you're thinking of the comparators that were included in the research. We identified two: lack of comparison to an optimal treatment versus just like an average treatment, and then lack of comparison to general wellness outcomes. But we only have two, so ranking will be easier on this one, but we'll give it a couple minutes. I think we're hoping that we missed some, and you will have the next slide to be able to add to that, but these are the two that popped out for us.
Given that there is only two, is there a way to say maybe both are important?
Yes, definitely. Thank you. Yeah, this question's a little tricky. So yeah, we will note that. Yeah. Okay. Yeah. We're gonna move on from this one a little quicker, I think, but thank you all for your responses. Let's go to the open-ended and see if we missed anything. In terms of comparators, like what would you like to see as additional comparators in future research, if there's anything that pops in your head?
Kelly, can you define comparators?
Yes. And Bethany, I'm gonna maybe, I think I can give a general definition. Bethany, if you want to add in specifics to the research, or if you want to take this question, please let me know. You are the expert and would probably be more articulate at it than me.
So the comparators that typically showed up in the evidence that we described were some sort of either placebo or an active placebo, like a really small dose of psilocybin, for example. But for example, in the survey studies, those surveys were also comparing different psychoactive substances, which may or may not give you the information you need to make decisions that you need to make. Sharissa, did you have a comment?
Yeah, I think the other way to think about this is, again, the legislature specifically asked for what are the clinical uses. This group has been very clear from the outset that, yes, while we recognize that is an important aspect of this, we also believe there is a huge role for psilocybin in general well-being. So as we think about answering this, it might be what are comparators that would be useful, given that the bulk of research that we reviewed and will include in this is from a clinical perspective. So whether that's, placebos that aren't niacin, or, CBT, other types of, psychotherapy interventions for depression, or pharmaceuticals, but also in terms of well-being, some of the stuff and mentioned here, psilocybin compared to non-psilocybin mediated other ways in which ancient indigenous communities practice. Just so kind of thinking about it in those buckets, because I think that will help as the legislature and their staffers read this, knowing that, yes, there's this clinical side that you asked for, but equally important from this group is that the well-being piece. And here are what we would like to recommend that we think about in that wellness thing. Even though you didn't ask us to, we're going to tell you what we think. So that might be a helpful way to think about it too.
Thank you, Sharissa and Bethany. Give it a couple more seconds.
Again, for my edification, selfishly, what is a baeocystin mushroom? I'm not saying that right, probably, but.
Donnie, I see your hand is raised. Do you want to add?
I just want some clarification to ensure that, like, we're not talking about comparing groups of people, like veteran versus civilian.
Yeah, I think that would be more of an underpopulation. This is more of like the administration, maybe is a better way to think about it.
Thank you.
Mhm. Okay, let's wrap this one up and move on to the next category, which will be outcomes. So we've identified these outcome gaps that were not in the evidence we reviewed. Some being general well-being, chronic pain, beyond low back pain. Low back pain was the only chronic pain we found in the evidence. Palliative care. We also add some suggestions for more outcomes. So more outcomes for anxiety. I think we also have more outcomes for depression on there. So kind of things that were missing, and then also things we thought maybe could be studied more.
And Beth, could you scroll that again? It looks like we've got a few more, if you don't mind. Thanks.
Yep, PTSD, anorexia, alcohol use disorder. Yeah, so we'll give you a couple minutes to rank these. There's also quite a few of these. How about 30 more seconds to a minute? We'll see how much movement we have. Thanks, Beth. Okay, it looks like things are slowing down. Again, if we close it too early, always open to your responses in the chat or via email if you missed any of these. Okay, let's move to the open-ended question for outcomes gaps. Anything we missed in that last slide related to measuring outcomes? And we only have one more category after this. Thank you all so much for being so engaged with this. Okay, TBI treatment, treatment-resistant depression. Impacts on families. Specific impacts, I mean, if there's anything you'd like to add, any level of specificity on impacts, that would be great. That's a great one. Thanks for adding. Oh, interesting. Okay. Feelings of connectedness, reduced isolation. Okay. How about another 30-ish seconds for this one? Oh, impacts on grief.
Could someone explain or articulate a little bit about the ethics challenges in studying bipolar schizophrenia? Is that in terms of the ability to consent or?
my thoughts on the ethics issue with the bipolar and schizophrenia is that both for bipolar and schizophrenia, the psilocybin compound is known to be a triggering mechanism that will spiral them down.
Got
And
it.
so that's the challenge, is to giving them this medicine that may cause them to go into an episode.
Thank you.
Great, thank you all. How about a couple more seconds and then we'll move on to our last category. Okay, the differences between bipolar 2 and bipolar 1. Okay. Okay, let's lock this one and move to the settings category, please, Beth. Thank you. So for this, we identified 2 gaps in the setting in these research designs. One would be unsupervised use, and another one would be use in non-research community-based settings. I realize that is a pretty broad category, so if you feel like you want to add examples under that in the next slide, please save those ideas. But and again, if you feel like both of these, there's only 2, so if they're equally important, that is also allowed if you want to record that in the chat or come off mute with any of your thoughts. We'll give this maybe a minute or so. Does anyone think there's like a big difference between these 2? Like if you're ranking community-based settings as #1, would you say it's far more important than unsupervised, or are they close? If anyone has any thoughts, just out of curiosity, for if they want to add to that, please feel free to come off mute or put them in the chat. That would be helpful. Similar. Okay, thanks, Cody.
I would say they're 2 poles of the continuum, and they are complementary. I would add that research-based community settings could make a lot of difference, and also it could be that unsupervised for microdosing, that's a no-brainer. But for people who are doing larger doses, it could be that after 2 or 3 supervised sessions, they're cleared for takeoff and can handle it on their own, or even in a small group setting.
That's super helpful. Thanks, Brian. Okay, let's lock this one and then move to the open-ended question. If there are any settings that you would like to see prioritized in future. Oh, whoops, did we miss the? Oh, look.
We had that one.
I forgot to add in that slide.
That's all good. No, I think we're moving straight into the Duncans. But Haley, that was a great overview and great feedback. I think, like you were saying, thank everybody for all that wonderful feedback. So a lot of that'll get incorporated in the report. So thanks.
Yeah, I think I did mean to put an open-ended question after that last one and missed it. So if anyone wants to add that in the chat or email, feel free to let us know. Sorry about that.
We're checking the chat now. So yeah, if you have thoughts, please put those in. We'll make sure to capture those. That's
Thanks,
great.
Mike.
Absolutely. Haley, thank you. Well, Duncan, I think we're up for regulatory survey results and discussion. So I may turn things over to you.
Yeah, that's great. Hi, everyone. I'm Duncan. So we distributed the survey about 3 weeks ago, and thank you all for your participation. I know it was an at times dense and slightly tedious survey, but I think what the survey is going to allow us to do is kind of go through the results, discuss them as always. Feel free to participate when you'd like. We're going to do some poll everywhere questions. The goal of these questions is kind of to allow you all, I think what we saw in the survey is that you gave feedback on Oregon, which since the beginning has been a model that the powers that be in Washington are thinking of kind of using as a model for what could occur in Washington. And so what I think this survey is so important for doing is being able to kind of look at a very detailed level on the rules and regulations in Oregon and give feedback to the legislature, the Washington legislature, and let them know we think that what Oregon is doing here is good. We think what Oregon is doing here is not so good. So we can go to the next slide. So like I said, I really appreciate all the feedback. I think it's produced a really a real wealth of information, and the poll everywhere questions. Apologies for continuing with all the surveying, but I think it'll be beneficial. Will give us a really good result. So we had 16 responses recorded overall. I think that averaged out to be around like 13 responses per prompt. Basically, each slide that I go through today will look like this. So on the left side, as you remember in the survey, there was the written response option. So I'll have a little summary of the results. And then on the right side will be the full data for each point. And so we're going to go through each section. There are 11 of them. And after each section, I will have usually 1 or 2 poll everywhere questions that are more often than not, they're yes or no. And the goal of these questions, basically, I look through the results, I put them into a chart, and then what I hope to do with these questions is take out the issues that were contested or take out some of the recommendations that seemed most viable from kind of your written responses and present it back to the whole group. So you guys get to give feedback on what aspects of Oregon's program should be changed or what should be kept, et cetera, et cetera. And so feel free to answer as many of these questions as you want. If you don't have an opinion, you don't have to answer. But I think the more you answer, the more data we'll be able to give back to the legislature and the more informed they'll be when developing their own program. So Mike, do you have anything to add to that?
Duncan, just one thing you may want to highlight. I may have missed it, but just on your grid on the right, your totals.
Oh, yeah, thanks.
You may just want to highlight that what that total means, so as people are tracking that.
Yeah, absolutely. So just to make it a little easier, you see the support, opposed, neutral, and need more info categories, and then I added a little calculation total. And so all that is just taking the support column and subtracting the opposed column. And so if the number's in the positive, it means it was mostly supported. And if the number's in the negative, it means it was mostly opposed. And so I have these little silly examples, but makes sense. And neutral and need more info just wasn't considered. So I think we can get right into it. Beth, if you want to go to the next slide. Okay, so we're going to start out with kind of the background information. What we saw was written support for collaborating with academic researchers in this process. We have the advisory board in Oregon under the Oregon Health Authority is made up of a panel of experts that advise the Oregon psilocybin program's rulemaking and policy. And so that's what exists in Oregon. And there was a minority opposition to the advisory board having no regulatory power. And so that was 7 support, 3 oppose. And we can go to the next slide. So the first poll everywhere question I have is actually open-ended. There are only a few of these. But what I'm asking for is kind of a response to that minority opposition. So the Oregon Psilocybin Services Advisory Board has no regulatory power. Should the advisory board that will in the future exist in Washington to the Department of Health have regulatory power? And if so, what points would this board regulate? What would the Washington State Advisory Board be in charge of kind of managing instead of it being left to DOH? And so feel free to respond. I'll give you around a minute for this and then we'll move on. Use cases licensing, yeah. Absolutely. And as we go forward, I figured I'd use this space during the poll everywhere for anybody to share any comments or questions they have about the results. We can always, as we get more into the weeds, skip back to the main slide and go over any details. Give it 30 more seconds.
Duncan, this is helpful. So thank you guys for doing this, because normally and Teresa can talk about this, but in a state bureaucracy, if there is an advisory board, it is advising an agency or a department. So like in Oregon, it's advising the Oregon Healthcare Authority. So this is different than setting up, a true structure where a board would have that regulatory authority.
Yeah. Okay, so I think we can move to the next slide now. Thanks, everyone. Okay, so facilitator training. This is the longest section, so bear with me. I'll stick to it. So overall, we saw a lot of variation in response approval ratings. In general, we saw, so anything in quotes that you see, just for the record, is a direct quotation from written responses from the survey. Anything not in quotes is either a paraphrase or just kind of an observation about the data. And so we have a question about comparing the 120 hours of training to other types of professions. We have several voicing support or voicing opposition to the high school diploma requirement, expressing that that might not be met by certain individuals seeking facilitator training. And then we have a majority opposition on training programs setting their own criteria for accelerated training. So we see that with the third, the fourth, and the fifth prompt, that there's overall either neutral or majority opposition to the training programs themselves, instead of the Department of Health setting guidelines for who can and cannot meet the criteria for accelerated training. There's concern expressed on the expertise level of HEC in Oregon. That's been brought up a couple times before in this task force. And there's been encouragement that Washington State does not put the training programs through our equivalent of HEC in Washington. And then we have $500 application fee is too high for some applicants. And then there's written support for more frequent education for training programs. So instead of a recommendation for every 2 years, as opposed to what seems like in the rulemaking, though it's slightly unclear in Oregon, retraining every 5 years for those programs. So that was kind of the data from here. I hope everything's making sense in in terms of the calculation total. We can go to the first poll everywhere question, Beth. So OPS rulemaking allows training programs to set their own qualification guidelines to bypass certain facilitator training sections. Should standard statewide criteria be developed for determining whether a facilitator can bypass certain training modules? Yes, and thanks, Mike. And Rick, I'm sorry, you could submit something offline, but I think as we move past these poll everywhere questions, they stay closed. Is that right?
It is, but Rick, please feel free if you want to submit either again via email or via the chat. We'll make sure to incorporate that.
Yeah, because just for more clarification, then all of this process is going to be post this meeting is going to be compiling these results and putting them in the final report, which you all see, so that these poll everywhere questions are going to be a concrete record of your recommendations to the legislature. Okay, and we're getting results back here. Okay, Beth, we can go to the next.
Duncan, quick question, and I don't, one thing that might be helpful, and I don't know how we do this, but going back to the earlier question where people voiced what they thought the advisory board should be able to regulate on, what would be helpful, I think, in the context of this report would be if there's some way we could poll the group to say also to that question, yes or no, should the advisory group have that authority? Because about, I think 5 or 6 people, posted what it should have the authority for, but that's 10 people silent that we don't know if they say yes or no. So I think that would be helpful if we can figure out a way to do that.
Yeah, absolutely. Creating these poll everywhere questions it was hard to isolate the issues that should be brought up and the ones that shouldn't, because there are so many important points kind of throughout this Oregon analysis. And so I'd be happy to, if you all can take it,
or folks can put it in the chat too, like Donnie did. I apologize, I missed that when I when you and I spoke, so I missed that too. But if folks want to put that in the chat, that would be helpful too, I think.
Yeah, absolutely. And I'm going to put in the chat the link to this is where the majority of this data for everything came from. So,
And Duncan, so we've got a question too from Dr. Smith.
Hello. Hey, Duncan. I was just going to mention that it's interesting. Some of these questions, I want to remind my colleagues on this call that this is a new profession. It's emerging as we're talking. So a lot of these questions that Duncan's putting out there, I think, are really we should take into consideration that all of this stuff is new, including HEC and how HEC is going about providing accreditation to some of these training programs in Portland, so in Oregon. So we need to be just cognizant of that as we go about, shaping the profession, this new profession that's emerging, whether it be called wellness providers, whether it be called facilitators, or whatever we decide to call it here in the state of Oregon. So, the state of Washington. So just recognize that.
yeah, absolutely. Thanks for that. I think that's really important to keep in mind. Okay, so I'm sure you guys have all read that response by now. Oh, got it. All right, so we moved on to the next one. I'm assuming everybody was able to get their response in there. We can go to the next. Thanks, Beth. So OPS training programs must renew every 5 years. There were multiple recommendations in the written rules that suggested that Washington should train programs every 2 years. So welcoming that feedback on how often training programs should renew. And absolutely, Paul, we should be able to adapt over time because, like Darren said, it's very new and really there's no precedent set.
And Duncan, I would just add, if there's something in between the 5 years and the 2 years, if somebody wants to put something in the chat, then we can capture that as well.
Yeah.
Does the training program renewal mean that the people who have taken the training need to renew their training every 5 years, or does that mean the training program must look at its curriculum every 5 years?
You see, that's what I knew that question was coming. My understanding of renewal is that the training program itself has to, like, when a training program applies, it has to kind of submit all this information, verifying that it will be doing a social equity plan, showing how the social equity plan is succeeding or not, et cetera, et cetera. So I think it's that process.
Okay.
Quinn, I see you have a question.
Yeah, sorry, I'm a little bit naive to that training program and all the details that's involved in it. So I'm just curious. I want to get a little bit more information before I say yes or no.
Oh, just yeah, on what the training program would have to renew in the process.
Sorry, can you hear me?
Yes, I could, but maybe you cut out the
Yeah,
second half of your question.
sorry about that. I was wondering like how extensive that training program is in terms of like how much it costs for them to do the training and to renew it, and then how much time it takes to get everything together, because that can make a difference in whether we say yes or no.
Right, absolutely. I think in terms of time, I can't give you a very concrete answer. I put the link to the rulemaking in the chat earlier. Takes about 1 year in Oregon, says Darren. And so that might be kind of to get approved in the first place. In terms of renewal, and then it does cost $10K, and that is true in Oregon. We'll be going over that later. In terms of renewal, I think it's resubmitting a lot of the curricula and proving that you're meeting all the training requirements that the state of Oregon, at least in Oregon's case, has set forth. And so that's like making sure you meet all 6 modules and are covering all the information that you need to cover.
All right, we ready for the next?
Yeah, I think we can move on. Okay, so this facilitator conduct, overall, there was really high majority support statements for all of these points. And there were some questions brought up. So has there been a comparison to other standards of practice on consent in other fields? So is what Oregon is practicing in terms of consent, does that compare to kind of other vaguely similar forms of practice? There was a point made that in tight-knit communities, people know each other well. So this may limit somebody who is well connected to the community, the restrictions on having financial engagements or romantic engagements with people in smaller community that may be harder when a facilitator is very engaged in that community. There was a statement that facilitators who speak a second language should be compensated more. And then another statement clarifying that interpreter rulemaking should also cover ASL for deaf clients. And then lastly, there was a written comment made that supportive touch restrictions put forth in the Oregon rules is overly restrictive. And so that was all the written feedback. In terms of actual support opposed, it was majority support. So we can go to the next. Thank you. And I welcome any comments on that slide. Should facilitators who speak a second language be compensated more for their services?
That's a great question.
And to clarify what I'll be representing the data purely, I won't be saying a majority supported. I will say this many supported and this many disagreed with each poll everywhere question. So I won't be kind of casting this group as one entity. There's going to be minority and majority results supported. How fluent does somebody need to be in the second language? Good question, Paul. I know there are fluency accreditation tests, so maybe going by that criteria. Okay, I think everybody's had a chance to respond to that. We can go to the next question, Beth. Service centers. So this, I think, is an important section that had kind of a lot of opposition to certain tenets. So firstly, there was majority opposition to allowing local governments to adopt ordinances prohibiting centers and manufacturing licenses in their county, et cetera, in their area. And so that was 6 oppose, 5 support. And so I'd love to hear some feedback from both sides on why there's supporting and opposing. And there's a poll everywhere question for this too, just to kind of reiterate that question and let people share their thoughts on that. There was minority opposition to service centers not being within 1,000 feet of the school. There was a suggestion that the 2-year requirement for state residency be increased to 5 years for an individual to be able to set up a service center, and then create a system that allows licensee to not have to renew their license every year once the center has existed for some years. So this would be a suggestion that would help kind of ease the burden on longtime licensees. Whether it's financially viable or not is a question that we can't answer at this stage. So I'd welcome any feedback on kind of any of those suggestions or points, and we can go to the next poll everywhere question too. OPS, this is just repeating kind of what I just phrased, but OPS allows local governments to adopt ordinances prohibiting or manufacturing service centers in the county. Should Washington state not allow local governments to adopt ordinances prohibiting service and manufacturing centers? And I put other down in case this issue is very complicated. And if people feel, I imagine there are people that don't feel that the answer is yes or no. And so I'd welcome those people, especially to kind of shed light on what they recommend as the in-between.
So I will admit I'm a little, so Washington state should not allow local governments. So to say no means we would agree with Oregon, but to say Georgia state not allow, if we say yes, Washington state should not allow, then we disagree with Oregon.
So Sharisa, so Oregon allows local governments to adopt ordinances,
right?
Right.
Yeah, thank you for clarifying that. I did make the wording more.
If we say we're not allowing them, that would be a different direction.
So can I add something to that?
Please.
So many of these governments in Oregon opted out of Measure 109. Basically, they didn't want to be part of it. They didn't want those hippies and people coming into their communities. Okay, so the question here is that in doing so, they've created a mess in centers, these wellness centers, being able to come into existence, and then creating a bottleneck of facilitators who are going through these training programs because of the way the law is written. So if we do the same thing that Oregon has done, we're going to have the same issue here. So we need to strike more of a compromise. And one of the compromises, I think, is that give the outlying counties 30 days to respond to this, and or they're automatically opted in, something like that. So or try to strike a balance with the counties that tend to be a little bit more hostile to these measures. Or I would start right now, if you're going to do a similar deal in Oregon, we need to start educating the communities outside of Seattle what this is all about. I think that would go a long way. So there's some things we can do. I think the city, I don't think we should do what Oregon has done. I think that was not a good move on the part of the law. And if you ask the people in Oregon, they'll say, at least the ones who work for their what is it, OPS division down there, they don't like that either. They think it's a barrier to access, and there's other issues associated with it. So I think we need to be a little bit more circumspect about it.
Thanks, Darren. Caitlin, do you want to? Yeah.
So in cannabis, we've been doing this for a decade, and that the issues of preemption are back and forth and back and forth. The uneasy piece that we found is funding, the flow of funding. So if there is any state revenue generated from this, it's sort of the piece that was made is that municipalities don't get a slice of that unless they allow for facilities to exist. And then it's up to those local municipalities to come up with what ordinances are in place in terms of closeness to schools, zoning type, for activity, et cetera, et cetera. I think you're right. It's very complicated. We want to make sure that we're not just having whole counties shutting down access for folks. On the other hand, I could say cities, we fought for the first 7 years between LCB and cities and counties about who gets to decide whether something gets licensed. And honestly, that is one of the biggest issues now that we are working on social equity. As we come back around again, we're back into that preemption fight between the state and cities and counties. So again, flow of money seems to be the how that is best managed rather than a dictate from one direction or the other.
Right. Thanks, Caitlin.
Yeah, great overview, Caitlin. Thank you.
Anybody else want to add anything? I think there's another poll everywhere question, so we can go to the next slide. OPS has a 2-year state residency requirement for establishing a service center. Should this requirement be changed to a 5-year residency requirement? And so to clarify, I believe how this works in the Oregon legislation is that if the majority of individuals who are under the employ of the service center at the time of its founding have not lived in Oregon for more than 2 years, that would be prohibiting it. So it's not just like one individual, it would be the majority of stakeholders.
And I would just say, like you did on the other one, is there something in between that could be better?
Yeah, absolutely.
Yeah.
Ben, to answer your question, there's a residency requirement to kind of prevent outside money, because there's so much funding in psilocybin right now from coming into the state and taking over what should be kind of local participation.
if I may speak to this one as well, we've had currently for cannabis, we have a restriction on out-of-state ownership and continue to have one. There has been legislation to change that in the legislature every single year since I-502 was passed. It was, I think, a nice thing in the beginning, but I'd say right at about 2-3 years, we now know that we are in this uneasy place that the moment that it happens, it's propping up some folks that just aren't going to survive it when it comes in, no matter what happens. And so our perspective is harm reduction at this point in terms of financial viability of businesses, because it will take some people out, whether the federal government makes that decision or the state makes that decision. And so I think if there is a residency restriction put in, whatever that year mark is, that there perhaps be some thought given to a step-wise effect that looks at residential privileges rather than just wholesale yes or no allowed, that can be phased in or phased out one way or the other.
So,
and by residential privileges, what do you mean? You like
perhaps like tax breaks, preferential zoning, I know Oregon, it costs more to have an outdoor facility that's a little bit higher of a licensing type, maybe first access to outdoor facilities, things like that.
Got it. Thanks.
Yeah, I think their residency requirement goes away in 2025 in Oregon. So, and I think that Colorado is not having a residency requirement at all. So, so we need to think about what do we want to do. I mean, anytime you have any restrictions, think about the cost or the effect that it has on communities of color when we're doing restrictions, or at least we should have some workarounds for communities in which this might impact from getting started to getting their facility started or off the ground, or however we're going to, however the legislator decides on how this goes down. But so I would think about that. So I would say there's no, residency requirement. I think that would be incredible. Or like Caitlin said, maybe a stepwise one, you've been maybe a year or two, then it goes up from there or something like that.
Sure. Thanks, Darren. All right, we can go to the next slide. Preparation sessions. So it'll go preparation, administration, and then integration sessions here. Overall, there was high approval in this section as well, and some feedback. So written feedback for advocating for psychospiritual care needed in the preparation and integration session. There was written feedback from multiple different people saying that there's this restriction, or there's this rule that states that preparation sessions should occur between 90 days and 24 hours before the administration session. And there's feedback that 90 days is far too far out before an administration, and 24 hours is a little close to an administration session. So perhaps reworking that range. Concern expressed that the preparation session does not include any formal therapy. Of course, there's a cost issue with that. Recommendation that after 3 sessions, a preparation session does not need to be performed beforehand. So what that is referring to is an OPS rule that once an individual has had a preparation session, an administrative session at a certain facility, they do not need to have a preparation session the next time they come back. And so this recommendation by a task force member was stating that it should be after 3 sessions that somebody can kind of circumvent the preparation session. And then lastly, there's a recommendation that preparation sessions be done in person. We can go to the first poll everywhere, Beth. Thank you. So OPS allows the preparation session to be bypassed if an individual has done a session at the same center before. Should more sessions be completed for the preparation session to be bypassed in Washington?
And just for clarity, Duncan, this is speaking to when a session is done for wellness, right? The clinical world and settings are likely going to have practice recommendations that, so just so I'm clear as we present this is for the wellness model.
Yeah, I think that's a good point. Yeah.
But Teresa, this is Mike. I just want to make sure I'm clear. These are the Oregon rules that exist today, though, for everybody.
Right, but the Oregon rules are not focused on a clinical model only, right? They're or it includes clinical and
This is
wellness.
the minimum standard here. So if somebody wanted to increase that, they certainly could.
I see.
But you're right, Teresa, that OPS doesn't address any sort of clinical setting in these rules and regulations. Yeah.
Right, that's what I'm saying. Because if you're treating someone with treatment-resistant depression, you may want to, it's going to be different than someone who's seeking care for a non-clinical condition. So just trying to figure out how that fits with this question is all.
Yeah, absolutely. All right, we are all tied up. I did not expect that. Anybody have anything to share on this? I'm
curious because they don't have, you're not saying how much time is between sessions. So would it be like if they have a session 1 week apart, they still have to have like another prep session, even if they've had, let's say, an integration session, can that count? Or are you saying that like they actually have to have 2 separate preparation sessions, or is that for a certain amount of time that has passed?
That's a good point. In the Oregon, somebody had a written response to that. In the Oregon rules and regulations, they don't have any sort of time restriction, but I think that could be a fair suggestion, is that if the preparation sessions are more than blank amount of time apart, 6 months apart, no matter what, a preparation session needs to occur. But if it's, like you said, every week, or if it's 2 weeks apart, there doesn't need to be a preparation session.
And Duncan, I'm just tracking. Oh, good. Teresa, please go.
No, I was just going to ask Caitlin if she'd speak a little bit to her comment. Just, is it referencing all these questions or this specific one around how many facilitation session time? I'm just so we can present that accurately.
Sure. I guess, and I'm going to answer that with another question because I was late to filling out the thing. I was waiting to talk to a friend who's been going through a training in Oregon right now. And I just kept asking her, well, why is it like that? Why is why are we setting these standards for some, from my perspective, a regulating body should be setting standards for safety's sake, right? And things like this seems to be a pretty arbitrary safety standard. Like we don't have anything that says that this makes sure that this is safer than any other way of doing it. And rather that should be decided by the practitioner of, what's required for the desired outcome, because depending on why you are going through the process might answer this question of whether or not it should be 6 months, or you know what I mean. And so again, that should be set by the American Psychological Association, or the, whatever the standard set of ethics is for this practice should be done there, not by state regulation.
Again, this is a new emerging field, Caitlin. This is all new. And so
I know, and we should be able to learn from Oregon and be able to say, this feels very arbitrary.
The American Psychological Association really has no sway in this new emerging field, right? So
that was just an example, or whatever, or the, I understand what you're getting at, and I actually agree. I agree with what you're saying. It just, again, this feels very arbitrary and not at all based on, I think, common knowledge about what sessions are like with people.
We need some way to standardize the training so that we can somewhat ensure that the public safety is being, taken into consideration with these new emerging therapies.
So how do these standards ensure safety?
Well, it provides the facilitator or the wellness provider, whatever this person or people will be, with some standardized way of approaching clients, right? And using a specific counseling methodological influence, such as maybe IFS or some other, well-known intervention, and that's coming primarily from the MDMA assisted training that MAPS put on. So to me, there needs to be a way to help bring this new emerging field into some sort of a standard, rather than sort of the Wild West of hey, just do your thing and whatever. I mean, I think that would be irresponsible for states to have a rollout like that. I think this is why they're we're having these meetings and trying to make some sense of all of this. So in my opinion, there needs to be a way to regulate this or properly make sure that people are getting kind of the same stuff, and how they apply that stuff during their everyday practice is up to them, but they're getting the same material that's needed to help regulate whatever this field will be.
Yeah. So I guess what I'm hearing in that is then, these are essentially not so much safety standards, but research methodology in order to establish safety standards.
Yeah, listen, Mike, I mean, I think these are the initial sideboards. Those sideboards could get tight, they could get widened, right? And you guys are reviewing these and saying, hey, for us, is this the right step right now? And that's all it is. And then within those sideboards, right, people can then practice differently if they wanted to. If they could have their own rules of saying, no, you have to have more sessions before you would be able to bypass that.
I think I see Rick had a question. The only thing to keep in mind here is this is specifically if we are making recommendations in this report on which ones do we think Oregon's might have it right, or which ones do we think, no, Oregon, we have some concerns about the way Oregon is moving forward in this. It will not be this group that sorts all this through. We can put what the group thinks, and then whatever advisory, regulatory, whatever structure is set up by law, ultimately, they will be the ones to address this. But I do think it's an important point that Darren made, that initially there's got to be some, I would think initially some sense of standardization with enough leeway for practitioners to decide what is the best for that individual in that setting, but that the only way to be able to measure how or if this is working, which that wherever it's funded, people are going to ask for some sort of evaluation, is to have some sort of set way in which to do that. So just, I think we're trying to rightfully combine a lot of things in one, and it's clunky.
Of course. And if then I might refine how I want to address the original question that got us into this discussion. And that is, I think my agitation here is when we're setting policy, and what we learned with cannabis is we did a lot of things at the beginning based on that philosophy of, this is new and we're trying to sort things out. And then now a decade later, some really sort of arcane, by the measure of a brand new industry, are still on the books, and they are become really hard to change, that are not serving either the industry or consumers or patients, and so I just want to be really circumspect about the level of restriction being put in terms of, is this really truly, is this necessary for safety? Because 10 years down the road, we may discover that this feels pretty ridiculous, but it's actually very challenging to get it changed. And so I think that's my caution.
Great caution. If there's some other comments, please, and Duncan, I don't mean to intrude. I just want to make sure we're keeping going, because I know you've still got a lot to get through. So I just want to be cautious.
I do. I think we're on track, but I think we can move on.
Rick, did you have a comment?
Yeah.
Yeah, I just wanted to mention something that Darren mentioned with the MDMA studies for treatment-resistant PTSD that MAPS has been leading. In regards to safety, the reason why those results were so positive is because the number of PrEP and psychotherapy sessions each participant received is up to 40 hours, right? So that's something to consider. And anyone that's undergone any kind of research setting or ceremony overseas or in your home community, it's pretty deep spiritual experience someone can have. So it can be different every time. So preparing for this is very important, just as the integration sessions are more important.
Rick, thanks for that. And Ben, I saw your earlier comment too, kind of solidifying that in terms of the importance of the PrEP session.
Yeah. And we can go to the next session, Beth. The next question. OPS allows preparation sessions to be done virtually. Should virtual preparation sessions be allowed in Washington as well? And so I think to weigh in, because both of these questions address the same thing that I've seen, like kind of looking through all these Oregon rulemakings, is we're often finding like the Oregon rules trying to strike this balance between safety and cost. And unfortunately, in many cases, those two things are opposed, and both are such important issues. Safety is incredibly important. Cost and access is incredibly important. For this question, it's really virtual preparation sessions would save money, but do they inhibit the ability of the facilitator to truly understand the client's needs and therefore run an effective session? And that's kind of the question we're answering. Okay, great. I think that was enough time for everybody to get their responses in. We can go to the next slide. So administration sessions. Overall, pretty high approval, except for the fourth slide. There's a recommendation that during administration session, the facilitator does not need to be present, and the administration session could be done by video call. So that was a recommendation. Backup facilitator should be available, but does not need to be a facilitator. This could help lower costs. So there could be some position that allows, there's regulation in Oregon that requires a backup facilitator to be on call, but that person could have a lower level of training, et cetera, is the suggestion. And then lastly is the microdosing discussion. There's opposition to requiring a session for a dose of 2.5 milligrams of psilocybin analyte or less. And so there's a comment that a non-intoxicating dose should not require a session or should be in a facilitation center at all, et cetera, et cetera. And so we can go to the next slide because it's going to refer directly to that. So what dosage bracket should have a reduced from 30 minutes, which is the current dosage bracket for 2.5 milligrams of psilocybin at the moment in Oregon, administration associated with? Yeah, so what I'm asking is if there were to be a dosage bracket that had a reduced amount of time in a facilitation center, if that's a better model, what would the dosage bracket be, and how long would the session, if the session should exist, how long would that last?
Dylan, could you, or Duncan, could you go back a slide first before we vote? Is it too late to do that?
No.
So a facilitator, a backup facilitator, but does not need to be a facilitator. Could you, to help facilitate, so the person who is at a different level of training for that backup facilitator would have, if the other one wasn't?
Yeah, this is a written recommendation. I interpreted it as I explained it. I'd be, if the person who wrote that is on now, I'd be welcome for them to share their thoughts, but that was my sense of it.
I might have done this, and I'm just thinking with the studies that were done, if someone was licensed there, this is more of a well-being community center approach. The secondary or backup person wouldn't need to have all the qualifications, but maybe be of a public health, community health worker or of some kind, and be aware of how to be in a supportive role. That's what I was meaning by that there, and it having this just coming from more a wellness model versus clinical setting.
Right.
Okay. Thanks.
Okay, Beth, we can go back to the question if everybody's all good on this slide.
I was waiting for Paul to jump in on this.
Yeah.
I'm not sure if I understand this entirely, so I'm not sure how to respond.
Yeah, that's all right. I can share. Basically, the dosage that you receive in a psilocybin session under Oregon's rules and regulations right now correlates with a mandatory session length. So if you take, I think between, and it's on the last slide, but if you take between 10 and 15, it's a 2-hour session. At the moment, if you take under 2.5 milligrams of psilocybin at a session, you only have to stay at the facilitation center for 30 minutes. And there was opposition feedback to that. And so the question is, what should the bracket be and how long should the session be? If that were to be a model that this task force would suggest.
Thank you.
Yeah. And you all, I haven't distributed it yet, but you all receive like full text for all the feedback. And this is what's in this presentation is mostly what was kind of shared in the survey, but you'll get a full text PDF of all this.
Duncan, can I just, Paul, I saw you put a note in the chat, but is there anything else here that you would want to call out that we could capture for this one?
Yeah, this speaks to standardization. If you're going to be prescribing or making recommendations based on milligrams, the wide variety of the concentration and different strains, different preparations, different cultivation methods, different drying methods, all these are mitigating factors. So we need to have an expiration date, a date of analysis, similar to what they have in cannabis already. But I think expiration dates are important. A surprising research showed that air-dried Psilocybin cubensis had much higher potency than freeze-dried, something that I would not have guessed. And so the variation in potency of the mushrooms, we can't use the mushrooms, even though we're an advocate of the natural form, it's got to be standardized to accurate number of milligrams of psilocybin. And we will get more and more information at room temperature, the rate of decomposition. There's probably a generalized rate of decomposition that will occur over time. So I do know below 2 milligrams, I don't think this, you shouldn't have to be in anywhere. I mean, you should be able to get your less than 2 milligrams and, you know, go pick up the kids. I just don't see that as an intoxicating or a dose. When you start getting towards 3 milligrams, then many people start feeling effects. The individual sensitivities here is there's a bell curve, and we're trying to amortize this on one static plateau. And I think that's very dangerous because some individuals will be more sensitive. So it may be, you know, that at the 2 to 3 milligram dose, that the first time the person's coming in, they're observed. That way you get an idiosyncratic, you know, personality reference standard for that person. And then the health provider or the provider then could be the ones that could say, okay, you know, if you're going to come in for microdosing, you're less than 2 milligrams, or, you know, and make that adjustment based on the person's experience. Ask them, do you feel intoxicated? I think most people would be pretty honest about it. So I think we should be very careful painting the canvas with one brush. Individual sensitivities are huge. Variability in the mushrooms are huge. Set and setting, and even what you ate that morning is going to have an effect. So all these things being true, I think the best that we can do is customize these ranges based on real world experience of the consumer first giving feedback.
Thanks.
Great. Oh, thanks. Yeah.
All right, we can go to the next question. I'm hoping to get to the social equity section at the very least as we run out of time. Okay, so integration sessions, as kind of we've seen in the survey and stuff, integration sessions have very little guidelines in the Oregon rules. So there's minority opposition to facilitators being required to use a non-directive facilitation approach for their integration sessions. And there was a suggestion that directive facilitation could be allowed if agreed upon in the initial preparation session. And then if the training is effective, and as a result, you trust the facilitators, they would need much broader discretion in the integration session. And then lastly, what we're getting into now is kind of the long answer text ones. And so I'm just going to kind of summarize through these, but the first written response recommends referrals to actual therapists, recommendation of more open-ended sessions, and a recommendation for psychospiritual care. So we can go to the next slide. OPS has made integration sessions optional. Should integration sessions be mandatory in Washington? So, and for clarification, the integration session is the session post the actual mushroom trip, where there's some form of kind of abbreviated kind of therapy and processing of your experience.
Duncan, why don't we give folks maybe another like 5 seconds? We're going to keep moving through these.
Yeah, we are. All right, great. Okay, thanks everyone. We can go to the next question. Should directive facilitation be allowed in an integration session if agreed upon in the preparation session? And for clarification, directive facilitation is kind of, as the name sounds, giving clear instructions, setting specific goals, providing feedback and guidance, as opposed to being a more passive facilitator in the integration session.
I'm just reading chat, and Seth, I just saw your chat, like the finality of yes or no, and I think we're pushing you, right, for yes or no responses, which can feel difficult. But as I was talking to Caitlin, I mean, these are the kind of the sideboards, even kind of the organ side. So it doesn't mean that people couldn't do more. You were just trying to figure out like what is that kind of that foundation that Washington would want to have in comparison to what Oregon's done.
Okay, thanks for everyone's feedback. We can go to the next slide. So group sessions are a really interesting topic, and I'm glad they were included in the Oregon rules and regulations because we've discussed them a lot in our earlier task force meetings. So minority opposition for a 25-person maximum per group session. There was kind of questions asked of the feasibility of having all the clients meeting each other in a big group session, so which was something that is mandatory under the rules and regulations of Oregon. And there is kind of another question asking if there should be other safety measures that exist in the case that this is not feasible, in the case that everyone should be able to like kind of screen each other and meet each other. And Caitlin, your comment, there is a ratio. And so you'll see that 4 down on the right there. It's in tiny font, but that's the ratio. And it goes by dosage, apologies. But also I believe there is a group setting ratio that'll be in the full report. 5 milligrams of psilocybin analyte or less should not require supervision, going back to the microdosing debate, and then separation of clients from others if a client is being disruptive should be mandatory. And so in Oregon rules and regulations, that's referring to the fact that the wording is should do their best. And so we can go to the next slide. Here, OPS states that written consent must be given for group session participants to touch each other. If a client is disruptive, facilitators should attempt to separate the client from the group. So those are some safety measures written into Oregon rules and regulations. What other safety measures should exist for group sessions for Washington State? And I'll give you some time to write this. I just wanted to kind of crowdsource some more guidelines because there was a bunch of written responses expressing that there should be more safety measures surrounding group sessions.
We'll give you some time, but not much time.
Absolutely. Yeah, we'll give 30 more seconds. And if that's not enough time, please just, I'll put my email in the chat. Feel free to shoot them my way and I'll put them in the final report.
Yeah, great. Good comments. Yeah.
Okay. Thank you everyone for your comments. I think we should move on and keep going. social equity. So I wanted to get to this part specifically. It's really important. There's a lot of interesting discussion to be had here. And if we need to cut off the last two sections, we can, though I'd love to get to those too. Recommendation that sales tax should be 7 to 10%. Majority opposition to mobile centers not being permitted. In fact, the most opposition of anything in the entire survey. Mobile centers would help with equity and access. There's means and ability issues, et cetera, et cetera. Comment that there's a need for a no-cost path for religious and nonprofit tracks. And then kind of talking about the issues with the 50% license fee reduction, which is something that Oregon is doing. So for nonprofits and other such groups and those who qualify under certain social equity guidelines, the $10,000 licensing fee is reduced to $5,000, which of course, still a lot of money no matter what, but that is a effort they made towards equity and reducing fees because they have to fund their entire program with the licensing fees that they win back. So we can go to the next slide, the poll. Oh no, not to the poll everywhere. Okay, so there were 2 social equity written response questions, and I'm just going to go over them real quick. Sliding scales are recommended. Recommendation for a list of sample equity plans. And then lastly, a critique of the entire structure being developed is commercial and fundamentally extractive, and that our approach needs greater cultural and religious sensitivity. So that's a really fair point, and anyone's welcome to speak to that. But that's a sum up of those. We can go to the next slide. And then what else should be recommended to Washington State as methods to promote equity in a future psilocybin program? And so we see multiple recs for a permanent equity subcommittee, which is very important. That's what Oregon's doing. Another sliding scale rec, and then a rec for no cost religious and nonprofit paths from the start. And Darren adds veterans. Okay, so now we have poll everywhere questions for social equity. Firstly, mobile service centers. Should mobile service centers be permitted in Washington if safety regulations can be properly maintained? Of course, I realize that is kind of the caveat is, can you have mobile service centers properly regulated with safety insured? But I wanted your feedback on the approval for mobile service centers in general.
I think you're there, Duncan.
Awesome. All right, next. That's what I expected. Should a future Washington psilocybin program recommend the use of a sliding scale fee in service centers? These may feel obvious, but I think it's important that we have this record because then we're going to see unanimous approval in the results, and then that'll be sent to the legislature. Okay, great. Thanks for that feedback. And then lastly, one more. OPS has established a permanent equity subcommittee. Should Washington do the same? Great. Thank you for your feedback. That's kind of what I expected, but I appreciated it. We can go to the next slide. Okay, so now this is kind of going over the safety results. Once again, it's a lot of recommendations, recommendation for a release of information to be signed, concerned that group sessions are far more stable than one-on-one meetings, recommendation for the screening of psychoactive drugs in the system, recommendation that referrals to therapists should be mandated, and that small dosages should not require entrance to a service center. And then lastly, somebody pointed out that mushrooms have been used for millennia, do not overregulate on the risk safety plan. And I think that's a fair acknowledgement. Apologies for skipping through these quickly, but you'll have a record of all this. These are all really important comments and I appreciated them. We can go to the next. What other safety concerns should be addressed directly in the rules and regulations process in Washington? And we saw a couple recs on the impact of family members and children, advocacy for a transportation plan, which is in Oregon rules and regulations, which is, I think, an important tenet. Make sure exclusion criteria are followed. First Peoples must be included in rules and regs process, and acknowledgement that there's limited data on high-risk populations. And then a recommendation for 100 grams of psilocybin or less to be permitted for non-commercial use, and that all people with psychiatric disabilities should be able to access these services. So once again, really good recommendations. These will all be going to the legislature. I have one poll everywhere for the safety. If we can go to the next slide. This is taken from the recommendations. Should referrals to therapists be mandated in Washington State integration session guidelines? So obviously this doesn't have anything to do with cost or even a partnership between service centers and therapists, more of a question of should there be some sort of recommendation of therapy from facilitation centers?
In OPS, do they require it for everyone or just people that the therapist, that the facilitator thinks would benefit?
Yeah, it's as the facilitator chooses, which is a fair model.
Okay.
In Oregon, yeah.
And this would be, the way this is worded would reflect that, or this would be for everyone? The way this
Yeah,
is
by
worded.
mandated, I meant this would be something that is always encouraged, almost in replacement of an integration session. Yeah. Good question, Paul, for microdosing too. Maybe we can make an exception for microdosing. All right, we still got a little movement, but I think everybody's had time to get their responses in. Oh, we're still going. Give it 5 more seconds. Okay, interesting. I didn't expect majority yes there. We can go to the next slide. Great, and we're almost there. Licensing. So there was an error in the survey. I said Department of Health in Washington. I meant in Oregon, but it's also true that whatever comes out in terms of a program in Washington, the Department of Health will also have to reimburse 100% of the cost of operation, unless they get assistance, financial assistance from the legislature, which is unlikely. Recommendation that a percentage of licenses should be put aside to address equity concerns, so be given to people who apply under the social opportunity program or something like that. First people, indigenous and religious users need automatic exemptions from the facilitator license or should be fully independent of state regulation. So that's a comment that was made. And then lastly, concerned that the 10,000 equity license fees are too high. So we can go to the full everywhere question. And so just to repeat what I just said, first people, indigenous and religious users need either exemptions or should be allowed to operate fully independently from a Washington psilocybin program.
Does this mean to like set up a facilitation center, or does it mean to operate similar to now using it in their own indigenous and or religious ways in which they're being used now?
I read this recommendation as practice independently from whatever structure Washington creates.
Got it. That should be allowed to continue. Okay.
Sunil.
Hey, hi, Duncan.
Hi.
For my earlier comments about the merging understanding about spiritual and religious attitudes, as opposed to kind of predefined, systems of more colonial understandings about religion. I just wonder if it's just recognizing that everybody may have some kind of leaning in this way, even though it may not be defined by any particular clergy or whatever, maybe more equitable to say, all right, if we feel that people have demonstrated some degree of responsibility related to their use of psilocybin, maybe if you observe them, then maybe then they're able to independently have it,
right.
And that way, whatever ceremonies they want to engage in, they can, and then not sort of setting up a different model, but it's sort of recognizing that not everybody's going to, be able to have access or have their needs met through a licensed facilitation model, but maybe through whatever community programs or community systems that they might have. So that way, it just kind of keeps it open. And instead of, you think of these as more like licensing people to kind of drive a car, okay, you've demonstrated that you can drive, you're safe, you're the what to be on the lookout for. So it's another way to think about that. And you can still accomplish the goal without having to apply a religious test.
Right. Thanks, Sunil. Yeah, I appreciate that. Thanks for adding that. Let's go on to the next slide. We've got one more slide. It'd be great to be done by 3:50. So manufacturing distribution, this is just kind of a bit of a miscellaneous. slide. Majority opposition for species being limited to Psilocybin cubensis. That's what Oregon's done. And that has been something that we've discussed here, and there's opposition for it. And then recommendation that the amount of psilocybin to be possessed by manufacturers and centers could be increased. That is in psilocybin analyte is more than the dried mushrooms, but still that is that recommendation stands. And so let's go to the last poll everywhere. OPS is limited to species to allow Psilocybin cubensis. Should Washington expand the species allowed in the psilocybin program? Oh. Thanks, Paul, for that clarification.
Yeah, thanks, Paul.
Yeah, I'll clear that up in the final report. Okay, everyone, thank you for doing that. I think that was helpful. I appreciate all your engagement. That's our last slide.
So Duncan, just one quick thing. So for those of you who have computer access, I'm going on my reactions tab, and over to the far left, we have your hand clap. I just wanted to give Duncan and crew a huge, thank you. That was an amazing amount of work just to get the survey produced and to get this all together and compiled. That really just an outstanding job to pull it together like this. So Haley and Beth and Duncan, really just thank you so much. It was really great.
Yeah, thanks everyone for your participation. Oh yeah, okay, so I guess this is still me. I don't think Lisa's on with us or Tavasi, but Rick, would you want to speak to any of this? This is just a summation of what we're up to. Or Teresa, we can go to the next slide. I'm also happy to talk it through.
I mean, I can just briefly reflect my understanding from the meeting I attended. There was an opportunity to allow a sort of interim survey to be done in collaboration with the Department of Health and a mechanism they use that I presented to the Equity Committee last week. And their take was that really they are focusing on including in the report what a budget proposal and staffing would look like, as we talked about, to really perform a well-vetted, thoughtful, community-based equity survey, unlike the one that we tried to put out online and really only captured sort of the usual folks who respond to surveys like that who are white, educated with computer access and kind of hanging around the computer. So my understanding, Rick, please correct me if I'm wrong, is that the equity subcommittee will be making recommendations for how to move forward in a better way to survey community, understand their needs in whatever work goes forward, including their suggestion that we submit a budget proposal. And we'll do that either way as part of our agency decision package. Whether or not it moves forward will be up to debate, but we will do that either way to sort of move this work forward.
Yeah, that's correct. Thanks, Carissa, for that overview. And then these are our next steps here. So it's been quite a bit of work, and I appreciate Duncan supporting and meeting with Carissa last. And we're looking forward to meeting with Senator Solomon on the social opportunity program and how to find more support around this piece we're looking at. Thank you.
Yes, I think that's all on our end.
So can we go to the next slide, Beth? Teresa, I was going to just hit a little bit on our timeline, if that was all right.
Please. Yeah, of course.
So again, what we teed up in the beginning was everything, kind of compiling all this information and putting it into a final report. We've got kind of a number of weeks set to kind of get the first draft in place. What we are looking at, as I'm looking at our to-do list and our calendars, we're looking at towards the end of October, might be towards the last week of October, to send you a draft final report. And we're cautious of like how much information we'll be able to take back and do, a full kind of rewrite. But what we were thinking of doing, that we will probably couple that with another Qualtrics survey where you can provide your feedback in a more streamlined way, so that we can actually then capture that kind of survey results and then go back right in the document and make those edits. So we want to make sure that we get your stuff, your feedback as quickly as possible. So as Teresa said, if we send something out to you towards the end of October, we may give you not much time, maybe a week, to turn something around and make sure you have time to go through this and provide the feedback within the survey. But that's what, based on the timelines that we've got, to then have HCA do their final review and then turn that over by the beginning of December. Great. I'm just checking chat. Okay, so if that tracked with everybody, just make sure we'll be have communication with you towards the end of October for review of the final draft report, kind of accompanying with probably a link to a survey where you can provide some feedback. Really appreciate it.
And I guess, Mike, if that was what you wanted to add, we are nearing the end of our time. I want to just offer for anyone on the call to share any last thoughts. And before that happens, I just want to thank you all for your continued participation. This has been a huge amount of work on your end with continued participation. And really, I can say from a state perspective that this has been a unique, and I think for me, a very rewarding process, having this much back and forth, having the facilitation of OHSU. Thank you, team, for all the tremendous work you've done in this. And then really having all of you participants' voices, because you're really much more expert in all of this than I am, and really appreciate your thoughtful contributions and comments. And what we end up with, will be what someone else decides, but we have certainly, I think, done our best to incorporate your voice and your feedback, and appreciate OHSU's comments. And I want to ask Lacey from our other state agency just to share any last thoughts she might have. I say she's come on, and then Sunil, I see your hand as well.
Thank you, Sharisa. And I did want to thank our colleagues at OHSU and all of you on the line. And it is an interesting and different and more engaging process. So appreciate everybody bringing their expertise to the virtual table here, and look forward to continued work together as this goes forward.
Sunil.
Oh, thank you, Dr. Fontinas. I just wanted to let everybody know about the latest in our federal court case regarding psilocybin scheduling. As you might remember, the state of Washington was involved in this case previously. The Attorney General's office as an amicus brief supporter, and also arguing before the Ninth Circuit Court last year. And so there has been like a next week on Friday morning at 9 o'clock in Phoenix at the Sandra Day O'Connor Courthouse, we're going to have oral arguments on this case. And if you might, just to sort of, I just want to let everybody know, this could be, maybe you'll read about it in the news, or maybe there'll be hopefully something that could be of benefit to what we're trying to do here. So we had tried to seek psilocybin access under the right to try law, and for some of my patients here. And in the course of that lawsuit, the DEA suggested that I petition for psilocybin to be rescheduled. So I did that with my attorneys, and then they denied that petition. So we're now, appealing that. And so basically the issues that we're saying is that the DEA is attempting to usurp the authority that Congress lodged with the HHS, which is basically healthcare authority version at the federal level, who should be the one making the determination on the medical and scientific evidence. So we're asking the court to send it to HHS for the review, just like you recently saw HHS's review for cannabis scheduling. DEA didn't do this with psilocybin. So we're asking the court to recognize that we gave sufficient evidence to require the DEA seek HHS's opinion, medical and scientific, on rescheduling. And that DEA should not be doing a national standard for acceptable or legitimate drug use. And anyway, and the DEA asked, let's just pull the case out of court and and just give us some more data. But we think that they're acting in bad faith. Anyway, so this is what we're going to argue before the judges on Friday next week. It's an open hearing, so if you know anybody in Phoenix, or you're going to be in Phoenix area, you're welcome to attend. And so, you know, I just wanted to let you guys know about that. Like I said, Washington State was involved in this case earlier when we were looking at right to try, but they did not choose to get involved when we were asking about rescheduling denial, which I thought was unfortunate. But anyway, this way you all can know and keep track, and hopefully maybe find ways to you know, raise this issue, because I don't think there's really any good reason that the DEA should be not moving this forward for review based on, of course, the wonderful evidence review that we just conducted here. So anyway, thank you so much for letting me speak.
Well, thank you, Sunil. Rick.
Yeah. So no, I wonder if there's a petition for that, for get community feedback to support more of that. But more on DEI, I think just outside of fairly recognized tribes and religious groups, and there is community members that are healers, mostly elders that are supporting communities in different ways, whether they're curanderos or doing massage therapy and whatnot. And I think we should consider too, as far as the facilitators, because you know communities usually go to them first before their doctors, and then working in collaboration, whether they get access, facilitators get grandfathered in somehow, or are allowed to use a service center to support their community.
Good recommendation, Rick. Thank you. All right, it looks like folks are needing to sign off again. So appreciate all your participation and dedication to this topic, and we will keep moving forward. Look for the draft report with a quick turnaround, and everybody have a good afternoon and rest of the day. So again, thank you all very much.
Thank you, everybody.
Thank you. Have a great day.
Carissa, should I? Oh, off. I will follow up via email.